I want you to picture something. Really just visualize it. You've broken your arm. It's bad. You're in a lot of pain. The bone is, clearly not where it should be, and the swelling is starting to throb. So you walk, or maybe you limp to your local healer.
Right.
They set the bone, wrap it up in some cloth, and then comes that awkward moment of payment. But you don't pull out an insurance card.
No.
You don't pull out a credit card. You don't even pull out cash. You walk out to your wagon and you haul in a bushel of potatoes. Maybe a small pig if it was a compound fracture.
It sounds like a scene from, I don't know, a fantasy novel or some prestige TV drama, doesn't it?
It really does.
But that was the absolute reality of American healthcare. And we're not even talking about ancient history. This is, the foundation of the very system we use today.
And then I want you to contrast that with today. You go in for, say, a routine 3-day hospital stay. You are not dealing with one healer and a pig.
Not even close.
You are interacting with potentially over 100 different staff members, from specialists to billing departments, all generating, gigabytes of data. And yet somehow you feel less heard than the guy with the potatoes.
And that is the paradox we are unpacking today. We are doing a deep dive into the history of the U.S. healthcare system, but we're doing it with a very specific lens. We're not just looking at the medicine. We are looking at the communication.
And we really need to call out who we are doing this for. If you're a nursing student, or you're prepping for your boards, or just getting ready to step onto the floor for your first clinical, this deep dive is custom built for you.
It is.
Because, and I think the source material makes a pretty damning case for this, understanding how information travels, or more importantly, doesn't travel, is just as important as knowing your pharmacology.
Absolutely. We are drawing from a really fascinating text that covers everything from, Benjamin Franklin's first hospital all the way to the communication maze of the Affordable Care Act.
It's a huge scope.
It is. So the mission here is to understand how we went from those intimate one-on-one house calls to what we now call mass communication within a hospital. And the big question we need to answer is this. Why is communication the one clinical skill that is arguably the most critical, yet often the least focused on in your education?
That is the $325 billion question, but let's not get ahead of ourselves. Before we get into the history, we have to define the landscape. Because when we say health communication, I think most people's minds just jump to a doctor talking to a patient.
Right, the classic image.
But the source material makes it so clear. It is way, way messier than that.
It's a web. It truly is. And if you're a nurse, you are the spider sitting right in the center of it.
Yeah.
The text breaks this down into really 3 distinct levels that you need to master.
Okay.
First, you have the classic one, interpersonal communication.
Which is also called dyadic communication in the literature, isn't it?
Right, exactly. Dyad just means 2 parts. So this is the nurse-patient relationship. It's the core. It's intimate, it's direct, and it absolutely requires trust. This is just you and the patient in the room.
Simple enough.
But then you step out of that room, and you enter the world of interprofessional and interprofessional communication.
Okay, hold on. Those sound identical. Break down the difference, because I feel like on a busy ward, those probably just blur together.
They absolutely blur in practice, but the distinction, it matters for how you frame your message. So think of intra as within.
Okay.
So interprofessional communication is a nurse talking to another nurse. Let's say during shift change, you speak the same language, you use the same shorthand. BP is 120/80. Patient is NPO. You don't have to explain the basic concepts. It's usually, smoother.
Because you're part of the same tribe. You have a shared mental model of what the job is, what matters.
Exactly. You've hit the nail on the head. But interprofessional communication, that's when you step outside your tribe. This is a nurse talking to a doctor or a pharmacist or a respiratory therapist. And this is where the friction happens.
Why? Is it just ego? Or is it something more structural?
It's often structural, and it comes down to training. The text highlights that these different professions have their own cultures. There's a physician culture, which is historically, very disease-centered and hierarchical.
Right.
And then there's a nursing culture, which is often more holistic and patient-centered. So navigating the space between those subcultures is actually a form of intercultural communication.
That is a really fascinating way to frame it. We usually think of intercultural as like American versus French, but you're saying a nurse and a surgeon are basically speaking different cultural dialects.
Precisely.
Yeah.
And if you don't understand the values and the communication styles of the other profession, messages get lost. The surgeon often wants the bullet points, just the actionable data, just the facts. The nurse often wants to tell the story of the patient's pain or their difficult home situation. Both are right. Both are critical pieces of information. But if they can't translate for each other, the patient is the one who suffers.
And just to broaden the scope before we, jump into, the time machine health communication isn't just clinical, is it? It feels bigger than that.
It's everything. I mean, it is political. Just think about vaccine mandates or, funding debates in Congress. It's pedagogical, which is just a fancy way of saying it's about teaching patients how to care for themselves.
Right. Patient education.
Exactly. It's institutional. It touches every single aspect of American life, from wellness to illness. Communication is the vehicle that moves care forward. If the communication breaks down, the care breaks down, period.
So keeping that very complex web in mind, let's go back to when the web was a lot smaller. 1751, Philadelphia. And of course, who else but Benjamin Franklin is involved?
Franklin is he's unavoidable in American history, isn't he?
Yeah.
In 1751, he co-founded the Pennsylvania Hospital, which was the first chartered hospital in the colonies. He even wrote a pamphlet, some account of the Pennsylvania Hospital, to help fundraise.
Of course he did.
But we have to set the scene for the listeners. 1751 is not Grey's Anatomy. It's not even close.
Right. Context here is key. We're not just talking no internet. We're talking no electricity, no phones, no concept of antiseptic surgery.
And diagnostically,
Wow.
You had almost nothing. No x-rays, no blood labs, no MRIs. And this is why this history is so important for nursing students today. I want you to just imagine for a second trying to diagnose a patient when you cannot see inside their body.
You can't.
You can't order a scan to tell you what's wrong. So what do you have left?
You have your eyes, your hands, and your voice. You have their story.
You have the narrative. That's it. Communication was the only diagnostic tool available. You had to listen to the patient's story. You had to ask the right questions in the right way. If you couldn't communicate, you couldn't treat. It was a very high-touch, very low-tech environment.
So where did the medical knowledge even come from? It wasn't exactly from standardized universities yet. I'm assuming it was mostly just trial and error.
A lot of trial and error, yes. And this is a bit grim, but the text we're looking at calls war the laboratory for medicine.
That makes a kind of brutal sense.
It does. From the Revolutionary War all the way to the Spanish-American War, the battlefield was where the big medical advancements happened.
Necessity is the mother of invention, I guess.
Exactly. You have a massive, sudden influx of trauma cases. Physicians had to figure out triage, sorting who can be saved and who tragically can't. They had to organize care in these makeshift outdoor stations. The very idea of organized systemic care is born out of the chaos of war.
So you're saying the hospital system, the way we organize units and things like that, essentially has military DNA?
In many ways, yes. The logistical side of healthcare was absolutely forged in battle. But back in the civilian world, let's go back to my potatoes.
Right. The barter system.
This barter system, it implies something about the relationship, doesn't it? If I'm paying you with a pig I raised, I probably know you pretty well.
You're my neighbor. You live down the road.
That's the critical takeaway. It was a high relationship model. The doctor wasn't a stranger. They were a member of the community. House calls were the absolute standard. But, and this is a huge but, there was a massive downside to this, let's say, cozy arrangement.
The education.
The education was purely apprenticeship-based. You only knew what your mentor knew.
So if your mentor was a quack who believed in, bleeding people for a cold?
You were a quack who believed in bleeding people for a cold. There was no standardized curriculum. You just learned by following someone around. Yeah. And the stats from that era reflect that.
Yeah.
Life expectancy was less than 48 years.
48. So great relationships, terrible outcomes.
Broadly speaking, yes. The personal connection was strong, but the science was incredibly weak.
And the world shifts. The Industrial Revolution kicks in. We move from the farm to the city. And this has to just completely break that house call model, right?
Completely. Urbanization just changes the math.
Yeah.
You can't do house calls efficiently when you have thousands of people packed into tenements. You need a centralized place for care. And this leads to the medicalization of care and the rise of the hospital as kind of a factory for healing.
And this is where the government finally steps in to clean up that apprenticeship mess, isn't it? Standardized licenses, actual medical school.
Yes. The famous Flexner Report comes out, standards are finally set. But psychologically, something else shifts in the focus of medicine. We move toward what the text calls a disease-centered approach.
Okay, what does that mean?
It means that as we develop new tools, microscopes, x-rays, we started prioritizing the objective data over the patient's narrative.
Ah, I see. So we stopped treating Mr. Smith who feels short of breath when he walks up the stairs.
And we started treating the pneumonia in bed 4. Exactly. The narrative, the communication, took a backseat to the biological fact, and this explosion of knowledge led, naturally, to specialization. Today, we have over 120 distinct medical specialties.
Which, I mean, to be fair, is a very good thing. If I have a brain tumor, I don't want a generalist. I want a neurosurgeon who does nothing but brain tumors all day long.
Of course you do. And the data supports that. Life expectancy jumped to 76 for men and 80 for women, in large part due to this specialization. But here is the deep dive insight for our nursing students. What happens to the patient experience when you fragment their body into a dozen different systems?
It gets scary. The text actually mentions that the word specialist itself can be intimidating.
It creates dis-ease.
Yeah.
And I mean that in the literal sense, dis-ease. Think about it. If your primary doctor refers you to a specialist, the subtext is, something is seriously wrong with you.
Right, this is above my pay grade.
Exactly. It creates anxiety. And anxiety, it silences patients. They become intimidated by the white coat, by the fancy title. They stop asking questions.
They feel small. And that creates a huge hurdle for a nurse because the nurse is often the one who's trying to translate between this high-level specialist and the terrified patient.
Precisely. The patient might just nod at the neurosurgeon, totally confused, and then 5 minutes later turn to the nurse and ask, so, am I going to die? The nurse has to be the one to bridge that huge communication gap.
So we have better outcomes, but we've accidentally created this communication maze. And on top of that, we've also created a massive bill. Let's talk about the cost of all this progress, because that technology isn't free.
The price tag of technology is immense. And we tend to think of technology as just the machine, the MRI scanner. But the text reminds us. Technology is the machine, plus the specially built room to house it, plus the technician to run it, plus the radiologist to interpret it, plus the maintenance contract to keep it all running.
And then the hospital down the street buys one, so your hospital has to buy a newer, better one just to compete.
It's the medical arms race. Competition in healthcare, paradoxically, often drives costs up, not down, because hospitals compete on having the best, newest toys to attract the best patients and the top surgeons.
And then there's pharma.
Oh, yeah. The pharmaceutical boom. I mean, penicillin in the 1940s, it changed the world.
Absolutely.
It did. And now we have over 1,500 FDA-approved drugs. We can manage chronic conditions that used to be absolute death sentences. But the spending is it's staggering. The source material cites over $325 billion in a single year on prescription drugs alone.
And this leads to a scenario that I think every single nursing student needs to be prepared for. The text calls it the dinner versus drugs dilemma.
This is where communication meets economics, right at the bedside. The source material asks this, rhetorical but very real question. If you could only afford one, how would you decide between buying food for your family for dinner and refilling your blood pressure medication?
That's a choice that no one should have to make in a modern society, but people do every day. And I'm guessing most patients don't just volunteer that information to their doctor.
They absolutely do not. Shame is an incredibly powerful silencer. A patient won't say, I'm broke. They'll just nod, they'll take the prescription from the doctor, and they'll go and throw it in the trash.
And then they come back in 2 weeks for a follow-up.
And their blood pressure is through the roof.
Yeah.
And the doctor labels them non-compliant.
That label, non-compliant, that's so dangerous, isn't it? It sounds like they're being stubborn or difficult on purpose.
When usually they are just struggling. And this is where the nurse comes in. This is critical. Through effective interpersonal communication, you can build enough trust to uncover that barrier. You can just say, hey, I know these copays can be really high. Is this going to be a problem for you this month?
And if you know the truth, you can actually help. You can call the social worker. You can call the pharmacy and ask about generic alternatives. But you can only do that if you ask the question. If you just check the box in the chart that says patient educated on medication, you've failed the communication test.
Exactly. You cannot fix a problem you don't know exists.
Yeah.
And in a high-cost system like ours, silence is often the biggest, most dangerous barrier to health.
Okay, so we have rising costs. We have people choosing between food and their meds. And so enter the government again. 2010, the Affordable Care Act.
The ACA. It's massive, but for our purposes today, let's look at its main goals. Expand insurance coverage, reduce costs, largely through the mandate for electronic medical records or EMRs, and promote preventive care by eliminating copays for things like checkups.
On paper, giving everyone insurance sounds like it would solve the communication problem, right? You get a card, you see a doctor, you build a relationship, you get better.
Ideally, yes. But the reality for many newly insured people and for the uninsured is that they rely on community clinics or the emergency room for their care. And the text points out a critical flaw here for communication: continuity of care.
Meaning you don't see the same person twice.
Almost never. If you go to a clinic today, you see Dr. A. In 2 months, for your follow-up, you might see nurse practitioner B. You never get the chance to build that interpersonal relationship, to build trust.
And nowhere is this worse than in the ER.
The ER is the ultimate safety net, but it is a communication disaster zone. It's rushed, it's loud, the providers are completely overworked, the entire model is transactional, not relational.
Get 'em in, get 'em out.
Right. So even though access to a provider might have increased, the quality of the communication often didn't. You can't tell your life story to an ER doc who has 5 other critical patients waiting in the wings.
And then there's the other big piece of this, the EMR, the electronic medical record. I know this is a huge topic for nursing students because they spend what feels like half their shifts staring at these screens.
The push for EMRs was logical on its face: make records legible, consistent, and easily shareable. And let's be honest, it was also about making billing and auditing easier for insurance companies. But for a nursing student, for any clinician really, the EMR is a classic double-edged sword. Yes, it holds the patient's entire history, but it can also be a massive barrier. If you are typing while the patient is talking, you are not making eye contact. You're communicating with the computer, not with the human being in the bed.
It turns patient care into data entry. I've heard so many nurses say they feel like highly paid clerks sometimes.
And the text warns that the EMR can completely replace the human element if we're not careful. It structures the conversation around drop-down menus and checkboxes rather than the patient's actual, messy human narrative.
To really visualize this whole modern mess, the text lays out a fantastic scenario: the 3-day stay. We started this deep dive with a farmer giving a doctor a pig. A one-to-one communication.
A simple diet.
Now let's look at a typical patient admitted for a routine, say, 3-day hospital stay for something common.
Yes, let's just walk through this. Who are they actually talking to?
Well, for starters, it is not just the nurse.
No, it is a cast of characters. You have MDs and DOs, and likely several specialists within that group, like a cardiologist and a hospitalist. You have RNs, LPNs, CNAs, certified nursing assistants. You have nurse techs. You have physician assistants, PAs, or nurse practitioners, NPs.
Then that's just the clinical staff who are physically at the bedside.
Right. And remember, these people all work in shifts: 8 hours, 10 hours, 12 hours. So every single shift change, the faces change. The nurse you trusted at 2 p.m. is gone at 7, and a new person is there. In 3 days, a patient might interact with dozens, maybe over 100 different individuals.
100 people, that's not a relationship, that's a crowd.
It is a mass communication experience, and behind the scenes, the web is even bigger. The notes you write in the EMR go to billing, they go to the insurance company, Medicare or Medicaid. If there was an error or a near miss, the communication goes to risk management. If it's serious, legal gets involved. The pharmacy is getting electronic scripts. The patient's primary care provider, who's not even in the hospital, needs a discharge summary faxed over. It's an explosion of information.
It makes my head spin just listening to the list.
It should. The analogy the source material uses is that modern healthcare is like conducting an orchestra. But I want you to imagine an orchestra where half the musicians just stand up and leave every 8 hours.
Oh, no.
And brand new ones sit down and have to pick up the song exactly where the others left off, without missing a single beat.
That is a terrifying analogy, because if one nurse misses one note in that orchestra,
someone gets the wrong medication, or a critical symptom gets ignored, or a patient falls trying to get to the bathroom. The complexity itself becomes the enemy of safety.
And this brings us right to the final analysis, the great and kind of tragic paradox of healthcare education.
That communication is the common denominator. It runs through every single one of the professions we just listed. It impacts every single outcome, from diagnosis and treatment to patient satisfaction and even hospital reimbursement. And yet,
it's not taught, or at least it's not prioritized.
Not really. Not when you compare it to the hard clinical skills. A medical or nursing student will spend years memorizing anatomy, physiology, pharmacology, hundreds and hundreds of hours. They might get one course or maybe just a few lectures. on communication.
It's just assumed that if you can talk, you can communicate effectively.
Which is an incredibly dangerous assumption. Knowing medical terminology, the specific language of medicine, is completely useless if you cannot translate it. The text makes a great point. What good is knowing the Latin name for a condition if you can't explain it to a frightened grandmother in a way that makes her both understand and feel cared for?
There's a skills exercise mentioned in the source material that I really want our listeners to try, especially the students. It's about the difference between being a detective and being a listener.
Yes. This is a simple but really powerful exercise. The detective approach is what happens when we're rushed and task-oriented. You grill the patient. It's just rapid-fire questions. Does it hurt here? How long have you had it? Have you had a fever? Are you allergic to penicillin?
I think we've all been on the receiving end of that. You feel like you're being interrogated, like you're a suspect in the crime of your own illness.
You feel quizzed. And what happens when you feel quizzed? You shut down, you give one-word answers, yes or no, just to get it over with. You don't volunteer the really important information, the fact that actually you stopped taking your meds because they made you dizzy or because you just couldn't afford them this month.
Versus the active listening approach?
Right. The exercise challenges you to just listen. Ask one good open-ended question like, tell me what's been going on, and then stop talking.
Just stop.
Just stop. Use nonverbal cues. Nod. Look concerned. But let them tell their story in their own words.
It sounds slower, though, and I can already hear nurses listening to this thinking, I don't have time for that. I have 5 other patients and a mountain of charting.
It feels slower initially. But the research on this is fascinating. It shows that if you let a patient speak, completely uninterrupted, they usually only talk for about 90 seconds to 2 minutes.
2 minutes, that's it.
On average, yes. And in that 2 minutes, you get the gold. You get the real story, the context, and you build the trust that actually saves you so much time later, because you aren't chasing the wrong diagnosis or dealing with a complication from a misunderstood instruction.
So it completely changes the goal. We're not just there to cure a disease.
We are there to heal a person.
Yeah.
And that requires a fundamental shift in power. Effective communication leads to collaborative outcomes. It shares the power. It invites the patient to be a partner in their own care, not just a passive recipient of it.
So let's try to wrap this all up. We have covered so much ground. We moved from this simple, low-tech, but very high relationship model where you paid with potatoes
to a high-tech, high-cost, but often dangerously low relationship model where mass communication just creates noise and confusion.
It feels a little bleak, honestly. The system itself seems designed to make genuine connection almost impossible.
The text actually ends with a really provocative thought on that. It suggests that the current system is self-perpetuating. It financially rewards the treatment of illness rather than the prevention of it. It rewards doing things to people, tests, scans, surgeries, rather than simply talking to them.
Wow.
As long as the money is in the cure and not the care, communication will always have to battle for priority.
So here's the final thought, the challenge for you, the listener. Especially if you are that nursing student. You are entering this machine. You are stepping into that chaotic orchestra.
You are the bridge. In a system that is designed for mass communication, you are the one person who can stop the noise for a moment. When you walk into that patient's room, will you be a data entry clerk? Will you be a detective just checking off boxes on your list? Or will you be the one who actually listens?
Will you be the one who notices that they can't afford their meds? Will you notice that they're terrified of the specialist's diagnosis? Will you be the human element that gets lost in the electronic record?
That is the choice you get to make every single shift.
Keep diving deep, everyone. Thanks for listening.